Yeah, please share again.
Okay. And all right, we should start as people are still with a few people in the waiting room as well as they have been admitted. So Chris will help also to help monitor the what do you call that, the chat room in case I missed anything, because today I just had one screen, so I may miss the chat. Okay, let's start the sessions for the day. So hello and very warm welcome to everyone who's dialing in across Asia. So I'm Poh Teck Lim. So Teck Lim is my given name. So I'm Teck Lim, your facilitator for today. I'm delighted. So going to guide you through today's Bridges of Hope virtual training sessions. So today's sessions is our third Bridges of Hope sessions. We did first one was on palliative care. Second one was on bereavement. And today that is the third one. I believe some of you may have attended the first two. If you have attended the first two, why not go to the chat and say me, right? Just let us know that you have attended our virtual session before and just type in me, right? M-E, me, that's it. Good to see you all back here for those who attended before. So we are excited to continue this journey on nutrition. Today's topic is nutrition in childhood cancer, which is a vital one. And we are thrilled to have 59 participants from 24 of our member organizations. An amazing thing is that, with this virtual platform, we can reach out to 12 countries at the same time. And from the registration survey, we also learned that 15 of the organization here, you already have a nutrition support program in place. That's great. And 7 shared that, you are still not running one just as yet. So today's sessions, hopefully, is a great opportunity. Whether you're here to enhance your existing program or looking for ideas on how to get started. So we have two great speakers who are going to share with us. So warm welcome again and thanks for making the time to be here. And this space, when we created Bridges of Hope, is a space for us to connect, support, and empower each other. And this is how we are able to strengthen each other, how we care for the children with cancer across our region. So before we dive into today's sessions, I'd like to take a moment to really reflect on this topic of nutrition, because across CCI Asia Network, we recognize that nutrition is not just a supportive care, it is essential care. Yeah. So for children with cancer, the right nutrition improves strength, reduces treatment, side effects, and we're going to learn more about this from our speakers. So today's sessions, before I move on to also give a little bit of introductions into our Bridges of Hope, I would like to welcome, officially open our session. It is my pleasure to introduce someone who has been a steadfast pillar in our shared journey, So that many of you may know him personally, or you have seen him or his name, right, across all the CCI Asia communications, because he played a vital role in guiding and representing our regional community. So Mr. Benson Poh, our regional chair for CCI Asia, has always shown unwavering leadership, and a deep commitment to strengthening the capabilities of our 53 member organization across the 25 countries. So you're going to hear from him also a little bit, how this project comes about. So please join me in welcoming Mr. Benson Poh, right, to deliver his welcome and opening remarks. Over to you, Benson.
Okay, thank you, Teck Lim. Is my voice clear enough? I'm not using the earphone yet.
Okay. Very good.
That's good. That's good. I think welcome everyone. But before I talk, I would like to reiterate again Teck Lim's call. When you just come in recently, just rename your name according to registration, and also put your organization so that Chris can put you in the right chat room or the later on, so we can discuss according to the list she defined. So, anyway, welcome to all of you. I think good morning, good afternoon. Yeah, more or less we're still in the afternoon Asia. Yeah. So actually, some of you may know me well, and but when I see go through the list, some of you may not. So I'm the current CCI Asia Regional Chair. I've been serving the CCI board since 2005, no 2008. Uh, so anyway, I think the whole training is about Enlace Asia project. Enlace Asia project is actually started in 2024. We have a donor support our growth of Asia, CCI Asia. Ultimate goal is to build capacity for our members. So in 2024, we did organization capacity organization assessment. So 30 something members joined the assessment, very detailed, and that's the reason that we find out that the mapping of the trainees, what they are lack of, what they want to do, and what they're actually doing. So from the different angles, we find out that the topics that we are doing now, the last two one, as Teck Lim said, the palliative care and bereavement, one of the two of the top list. And nutrition, actually, this one is also very important, as Teck Lim mentioned. And also, this is a CCI global direction for this year and next year. Hopefully, we can help members to build their nutrition program. So we just put this the third training or third workshop, put the nutrition program preparing for next year, because next year CCI Global will have a nutrition program launched so that we can help or support members to build their program. I think this training, this workshop is very useful. And the last two, we learned a lot, and we keep modifying it a little bit. But thanks to Teck Lim, being the facilitator and the mastermind of this training, because he's a professional trainer, and they really fix all the flow, what would be best for our members. And more important, after this workshop, is the post-workshop information or survey that may lead to more collaboration between our members or more support from CCI to the members about the nutrition program. So I hope this will be another very useful workshop for all the members attendees, and then hopefully it will lead to more cooperation, and everyone will be more contributing into CCI Asia and work together. So I'll stop here and pass back to you, Teck Lim. Thank you.
All right, thank you so much, Benson, for setting that context regards to how it comes about. And this is where we said, the Enlace Asia project, yeah. So, this is where, it's just more than just a virtual program. It is a commitment to building the capacity of all the 54 CCI Asia member across all these 26 countries, which Benson just mentioned. We did that capability, looking at the capabilities of the different organizations and their needs, and that's how all these topics are coming about. So in terms of what I call that, the program itself, we want to try to organize it as a quarterly basis. So this is where we want to connect each other, we want to support each other with practical peer and peer-proven strategies. And this will also help to empower us to turn our shared learning into local action. So this is very important. You're going to learn from speakers, and after we're going to put you into the breakout room, and the breakout room you have a time, to connect with each other, and that's where you also support each other. So today's sessions on nutrition and child cancer reflect that spirit, of connecting, supporting, and empowering each other on that. So before we continue, I still see on the list of participants, if you can also just rename, rename your name so that we can see which organizations you are with. So please help us to do that. Just hover your name on the participant list. Under your name, there are 3 dots on the right. click on it, there's a drop down, just rename that. Yeah. And also, before we continue, I'd like to give you a quick heads up. All right, our upcoming breakout session. Each breakout room will need one volunteer to serve as a moderator. It is a simple but important role, helping us to guide the discussion, keep track of the time because we're going to allocate you only 25 minutes, and to make sure that every voice is heard. So we are putting a small group, so about 7 breakout groups. So there's going to be a moderator brief and notes template, which Chris is going to put it into the chat. You can download that. And from the Zoom chat, you download that, you'll be able to see, you know, what do you call that? The role of the moderator. It's very simple. All right. It's very simple. Good. Now, for that, if I can just ask you for a moment to really look at this picture. We have people, you know, from where, you know, who are having breakfast, right? In Jordan, Lebanon, Iran, right? Iraq. I believe you're having breakfast or just had breakfast. And the rest maybe have lunch in Pakistan, India, Nepal, you know, Bangladesh. And for people like me in Malaysia, you know, and those in Hong Kong, Indonesia, you're having lunch. So quickly put into the chat, you know, what have you ate before joining today's sessions, right? Just quickly go that and just put it down. And excuse me for 1 minute, yeah?
We can't hear you.
Right, I'm back. Sorry about that. Okay, what do you have for lunch, breakfast? What do you have? Okay. Oh, fried rice. That's nice, Erlin. Veggie soup. How about the rest who put breakfast or lunch? What did you have? What food did you have? Right. Tea and white cheese sandwich. Wow, that's nice. That's delicious. Rice for lunch. What else? It's all included in the breakfast, lunch, and dinner at the same time. Okay. Eggs, cucumber. Wow, I like this machine. But masala, carrot cake, coffee for breakfast. Good. Wow. Now, looking at all those, right? Chicken and vegetable, tea, sourdough. Okay, so that's very interesting. All those things that you just put it up. So there's a lot of variety here, right? Which is perfect as we all are about to dive into the role of nutrition. Looking at all those food, you know. So imagine this from the lens of a child. Let's example, based on what you just put up there, what you ate. If you are to look at it from the lens of the child undergoing cancer treatment, so their energy needs are higher, their appetite may be lower, and side effects can make food taste or feel different, right? Not like what we put up there, how we taste it. It could be very different. So what seems like a normal meal for you when you share with us on that, it may not be enough or even appropriate for those people under treatment. So today's session is about bridging that gap. You learn what actually nourishes these children, what can be adapted from local meals, or how simple changes in food choices can make a big difference for the children. So as we continue, let's keep asking, whatever meal that we are serving to the children, you know, is this meal supportive, sustainable, and sensitive to the needs of a child in treatment? So to guide us through these important conversations, we are honored to have 2 incredible speakers joining us today. Yeah. So Miss Juna. I'm sorry, I can't pronounce your family name, Juna. Well, she's a pediatric oncology dietitian and research coordinator at Kanti Children's Hospital in Kathmandu, Nepal. She brings both frontline experience and academic depth to today's session. And she's currently serving as part of the International Initiative for Pediatric and Nutrition, or IIPAN. And Juna will walk us through key principles in childhood cancer nutrition, including how we can manage treatment, side effects, and support resilience through practical localized approaches. So let's welcome our subject matter expert on the nutrition, Ms. Juna. So over to you now, Juna. All right, your slide is up. So you know what? You're muted, Juna. If you can just unmute yourself and put the slide into
Really
presentation.
sorry for the technical error. Is it visible and am I audible now?
Yes, you're audible. You may want to put your slide on presentation mode. That'd be great. Thank you.
Thank you, Teck Lim, for this wonderful introduction. And I'm honored to be here and be able to present on this very important topic, that is the critical role of nutritional science in childhood cancer care. And sorry. Just a minute. I'm really sorry for this. Is it visible?
Yes, it is.
So good afternoon and good evening to everyone who are joining from different countries. And in this session, we'll try to learn the importance of nutritional science, how if is incorporated into the childhood cancer care can influence the treatment tolerance, treatment toxicity, survival, and overall quality of life.
Yeah.
I'm not being able to change my slide. Just a minute.
The slides.
Yeah. So maybe if I try now, then I can.
You can try one more time. If not, then I'll help you to project. Yeah.
Sure. Yes, I can.
Good.
Is the second slide visible for everyone?
Yes.
So let's start with the cancer epidemiology in children. So globally, every year, almost 400,000 children and adolescents between the age of 0 and 19 years develop cancer. And among them, there are avoidable deaths in low and middle income countries. They are specifically due to lack of diagnosis or miss of diagnosis, or sometimes delayed diagnosis. And not only because of that, but there are some problems like obstacles in having standard care protocol, and abandonment of treatment may be due to more treatment toxicity, that parents are frustrated to stick on the treatment and then abandon it, or maybe due to financial burden to them. And not just that, but the deaths are due to toxicity and the relapse of disease as well. If we see in this slide, we can see how Asia has more global incidence of childhood cancer and more global mortality rate as well. Not just that, because of that, there is discrepancy in survival rate in if we compare it with high-income countries and low-income countries. High-income country have more than 80% of survival rate, while it is limited to less than 30% for low-income countries, low and middle-income countries. So where the nutrition is for pediatric nutrition, why it is, pediatric oncology, why it is important for pediatric oncology. If we see at the malnutrition rate of pediatric oncology, it will be ranging between 40 to 90% for low and middle income countries and between 0 to 30 for high income countries. So why nutritional status is important? Why we are more emphasizing on malnutrition and nutritional status? Because it directly influences the overall survival. The overall survival is what we want to get if we put a child into cancer care treatment. And nutritional status have directly influenced the overall survival and event-free survival. Not just that, it has directly influenced the treatment-related toxicity and tolerance level of a child, pharmacokinetics and distribution of drugs, prolonged neutropenia, which ultimately increase the risk of infection to a child and make them caught with so many infections by so many bacteria or fungal or viruses, and which will eventually degrade the quality of life. So nutritional status has directly related to all these factors. That's why having good nutritional status is really important. If we see at the prospective intervention study done in Guatemala, which included 331 children with acute lymphoblastic leukemia from both standard and high risk group, it found that there was increased risk of abandonment in undernourished children. Not just abandonment, but the risk of relapse would also be increased in undernourished children. And the the good part, I would say, was they found that if a child is of normal nutritional status, or if he or she could survive for 6 months, or if they are malnourished at the time of diagnosis, but if we put some intervention so that we can make them into normal nutritional status in that first 6-month gap, then their survival rate would be equal to those of having normal nutritional status at the time of diagnosis. So we can say that nutritional status and nutrition effort is really important, though they are poor from nutritional status or overnourished. But if we can put some intervention and make them normal, then the survival rate can be equal to those of having normal nutritional status at the time of diagnosis. So malnutrition is a modifiable risk factor for survival of pediatric oncology. And so nutrition is important also to have better tolerance of chemotherapy or radiotherapy and have fewer side effects of therapies. And it helps us heal faster. And the nutrition support that we provide to a child getting cancer therapy, our main aim is to grow and develop them as per their age, and concurrently helping them cope up with the complications that they may face because of the therapies. So growing and developing according to their age, this while having the cancer therapy is really important. So adequate nutrition would help grow and develop them faster, and which will eventually maximize the quality of life. So pediatric oncology patients who are more at risk of having undernutrition. It depends on the diagnosis, what kind of diagnosis, which diagnosis they have, and what treatment modalities they are under, and what side effects they are having. Maybe they are having nausea, vomiting, diarrhea, severe mucositis. These also affect, the risk of having undernutrition. And the anthropometry, if they are already predisposed with the undernutrition or overnutrition, then undernutrition, then they are at high risk of being undernourished throughout the treatment time. And dietary intake. So if they are unable to meet their calorie, protein, or other micronutrient requirements, then this will also lead to undernourishment during the time of therapy. So malnutrition is one of the biggest complication of cancer therapy, which is like previously mentioned, the body demands more because of catabolism, because of increased metabolism in body, because of disease and the cancer therapy. And the complications like nausea, vomiting, mucositis, or any other problem may lead to decreased nutrient intake, will together lead to malnutrition. And we know that malnutrition is a modifiable risk factor for survival in those children. So it's really important that we take care of this risk factor really carefully. Along with malnutrition, other complications that a child getting cancer therapy may be seen are nausea, vomiting, constipation, diarrhea, loss of appetite and weight loss, oral and throat ulcers, and anemia. And there are many more than these, but these are related to nutrition. That's why I have kept it here. And we'll discuss about how to cope with these complications in the forward slide. So basically what we do as a dietitian whenever we see any child at hospital at first. So we try to assess them nutritionally. There are a few modalities that we apply for nutritional assessment that we'll discuss in further slide. But in this slide, I would like to emphasize that nutrition assessment is really important to, and it is the first step that that helps us identify in which criteria a child is, whether a child is more vulnerable to malnutrition in future, or he or she is normal, so that for now we need to give them time, or just a simple conversation would work to intervene them. So this basically helps us to classify children based on their nutritional status. And at our center, what we do is, if a child is malnourished, then we try to follow up them every day or every other days, so that we have, whether they are sticking on our plan or not, is there an improvement seen applying that plan or not. So that's why the follow-up is really close for malnourished children. But if it's for normal, then we try to make it every week, or whenever they are coming to hospital, we try to reassess them on their next visit. And so ABCD is modality is what we use for nutritional assessment. The dietitian or diet expert present in this meeting may already know about this assessment tool, but yeah, this is really important to incorporate all these ABCD method. And from anthropometric measurement, we at first measure height, weight, MUSC, skin fold thickness if available, and head circumference. So from that, we'll classify if a child is overnourished or undernourished or normal. And from biochemical parameters, we try to look the lab values of stool, blood, whether the iron profile is good or not, whether the LFT, RFT, and if a child is at the initial phase of treatment, then obviously we'll look for tumor lysis syndrome for pediatric oncology. So all these blood parameters we take consider so that we can revise our diet plan based on those values. And the third one is clinical parameters, which is really important to consider along with anthropometry, biochemical, and dietary method, because by looking at the color of skin, by looking at the color of hair, if a child is already catechic, whenever we see a child, these all are tools, signs that we use to categorize them, whether we need to give more emphasis on nutritional intervention or the normal nutritional intervention would work. And the dietary intervention, which the dietary method of assessment, which include 24-hour dietary recall or food record method or food frequency questionnaire. And 24-hour dietary recall is the mostly practiced because it's easier for parents to remember what their child had just before day, because of the stress of disease, and because they have come from far away from their home. So it's really hard for them to remember all the food stuff that they had, their child had from so many days. So 24-hour dietary recall is one of the mostly used and a common method that that is used to assess the dietary assessment. And along with that, have questioning what kind of food they are having in last week or last month. That would help us to identify whether they are including the protein rich diet like egg, meat, milk, and pulses like that, or whether they are meeting the vegetables or fruits intake as per need or not. So, and I have kept this slide because this would not be useful for all the children going through cancer treatment, but it's really important to consider the corrected weight of children who are amputee, because maybe because of osteosarcoma or any other disease where some part of their body is removed because of cancer. Sorry, we need to take care of that as well. To we need to identify what their corrected weight is using this formula, which will help us reflect their actual body shape and size. And here is a nutrition classification that we use to identify or classify a child based on their BMI for age, whether they are normal or severely wasted or overweight or obese, and from height for age, whether they are severely stunted or normal, and from MUSC for age, which will help us identify whether they are again severely wasted or moderately wasted or normal or good. Yeah. And we at our center, we use this we use IIPAN protocol, which has helped us a lot in referring to nutritional requirement just by having a look at one paper, which helps us identify the requirement of a child based on their age and based on their gender. So yeah, the protein and calorie requirement are given here based on different age groups, and also the fluid requirement. And so we at first assess child via ABCD method, and we classify them whether they are normal, overweight, or undernourished. So from that, our nutrition intervention starts. The first line intervention will always be the oral intervention that will include, counseling method, which will help them understand what calorie dense food or what nutrient dense food looks like, how to prepare it based on what is available at their home, and cultural preference, child preference, and based on the financial label that they have. So considering all, we plan diet for them. And if on follow-up they are not able to meet what was asked them to have, then we try to add oral supplements, which might include the commercial formulas as well, depending on what they are in deficient of. Maybe some are deficit in protein, or some are deficit in calorie, or some are deficit in micronutrients. So these all we consider and prescribe the supplement. And if a child is malnourished and they are not able to meet their requirement, though we added supplement to their diet, then we need to think of advanced intervention, maybe NG tube or G tube or parenteral nutrition, which includes total or peripheral parenteral nutrition. And the therapeutic diets, neutropenic diet, which is often discussed when we are discussing a diet in childhood cancer or any type of cancer, or who are really susceptible to infection. And glycemic diet, which we need to consider, because in the if a child is getting ALL treatment at the induction phase, if they are having glucocorticoid along with the peg asparaginase, then some child may have seen with hyperglycemia or pancreatitis, where we need to modify the diet to glycemic control diet, that I would say. So yeah, there are different diet methods that we need to prescribe based on child's condition. So let's discuss on which advanced diet support a child would need. If a child have functioning gut, then we have to go for enteral nutrition support. And if a child have no functioning gut, then at the time we need to think of parenteral nutrition. So let's talk about the management of complications, starting with the altered taste. Altered taste, is commonly seen in children getting cancer therapy, because the chemotherapy damages the taste bud that is residing in the tongue and oropharynx, because they have high turnover rate, and chemotherapy are made in such a way that they kill rapidly growing cells. So the taste buds situated in those areas are damaged. Because of that, the child may feel altered taste, maybe metallic taste, or like the food actually taste they cannot taste in such a way. So so if it's not managed well, then eventually it will lead to undernutrition. What are the management strategy? If a child is having altered taste, if we suspect them to have altered taste, then good oral hygiene is really important. Asking them to keep their mouth moist at all times, which will help them taste food better. And use of stronger seasonings and serve food warm, that is has also been life-saving for so many children here at our center. And avoiding excessive sweet food, offer salty and sour foods, and try new method of cooking and also, if we are changing some utensils of cooking, then that has also helped manage altered taste. And let's talk about anorexia and low intake, which is also due to early satiety. Anorexia is often described as low appetite, early satiety, and taste and smell alteration. And often children develop food aversion. That is, they don't like to see some food, or they will be nauseous if they see some kind of foods, especially meat. And if it is not managed well, again, this will lead to low intake and malnutrition may occur. So what management strategy we can counsel parents? To provide small but frequent meals, maybe 6 to 8 times a day would help them meet their requirement. And serve food on a smaller plate so that they would think that they are having small amount, but it will be of calorie dense, and make them nutrient dense. Maybe adding ghee or oil or whatever calorie densing method we do have, we can use that to make it calorie dense. Maybe they are taking small volume, but if it is nutrient dense, then it will add huge percentage of their requirement per day. And present food more attractively. This is a really helpful tool, because children are more attracted to the unique and different kind of foods. So if we are serving food attractively, then the child may take food. And meal times to be in a relaxed and pleasant environment, and let children eat together with all the social interaction with their parents or family members, and diverting them by talking about the pleasant moment they had in earlier days. That would help them deviate about and think about good time and have some food. And if all these intervention strategies do not work, then we do have the power, that is NG-tube feeding. So we need to have good nutritional status to make them have better cure. So if not by all these strategies, then we need to think of NG-tube feeding as well. And another one is constipation. I would say constipation is often underestimated side effects or complication of therapy. Parents don't complain of constipation often when they see us, and they come us with the complaint that the child is not having adequate food, and the reason is none of the above, like not nausea and vomiting, not anorexia, and not altered taste. And if we ask more, then we can identify that the child is not passing stool for 4 or 5 days or a week. And because of that, they are having discomfort in stomach, some may have pain and or vomiting, and because of that, they are not able to meet their requirement, which will eventually lead to weight loss or poor intake. So what would be the management strategy for constipation? We always need to think about three things, that is fiber-rich diet, fluid, and exercise. So we need to think of all these three important things, and above that, giving adequate time for toilet, and having a toilet time is really important for preventing a child from constipation. Next complication is diarrhea. Frequent loose stool, abdominal pain, and flatus is described diarrhea is described as this. And if it is not managed well, then again this will lead to infection or again weight loss and poor nutritional status. And in diarrhea, we need to consider adequate hydration is there or not in a child, and good hygiene, keeping rectal area clean and dry, and clear fluid should be introduced if child is not being able to tolerate the semi-solid or solid food, and elemental or semi-elemental enteral diet if according to the child condition, and NPO or TPN in worse condition. And here in diarrhea, I would like to emphasize that, in diarrhea, coconut water which is a good source of electrolyte, and ORS, of course, and soluble fiber-rich diet would help control diarrhea. And another important complication of cancer therapy is nausea and vomiting. So chemotherapy affect the vagal and visceral nerve, which that would lead to chemotherapy-related nausea and vomiting. If it's not managed well, it may eventually lead to food aversion and poor intake, which will lead to poor nutritional status. And the management strategy of this include adequate hydration, good hygiene, and I'm really sorry. I think so nausea and vomiting. We need to offer them with less spicy food and less smelling food, I'd say. We need to keep the spices level low and serve food cold so that the smell of food is not triggering the nausea and vomiting to a child. And again, for this nausea and vomiting also, we need to give more calorie dense food to a child so that though they have less food, but that would be nutrient dense. And often covering the food with some covers have been helpful in having some food during nausea and vomiting, because some children, whenever they see some kind of food, then they are nauseous and vomit immediately after seeing that food. So if we try to cover that food with something, then it would help them have the food. And again, wishful thinking and activities like storytelling is also a helpful tool for nausea and vomiting management. And stomatitis or mucositis, which is also important complication of chemotherapy or any other therapies. And so prevention is always better than a cure for mucositis, because if it's developed, then it's really painful and difficult for child to have some food. So there are few drugs like high dose methotrexate, which are probable cause of mucositis. So if a child is going to get high dose methotrexate, then we could ask them to have ice chips or popsicles before starting chemotherapy, so that the chance of them getting mucositis would be reduced. Or if a child is already having mucositis or stomatitis, then at the time, offering them cold food or food with added ghee or oil, that would not affect or that would not further burden the pain due to mucositis. And we need to avoid the highly seasoned food as well here, because that would further cause irritation, and avoid hard food. And if not these things are working, then we need to think of enteral or parenteral nutrition according to the need. and the complication like liver damage is very toxic, but not seen frequently, but if seen may lead to um, increased risk of infection and bleeding in GI tract, which is really fatal. So at the time, we need to think of protein, sodium, or fat control diet, and supplementation of milk thistle may be beneficial. This is from this study, but at our center, we don't use milk thistle because it is not available, and because of availability and all. And renal damage. So some chemotherapy are really toxic to kidneys, and if it's not managed well, then loss of minerals or loss of protein from kidney may occur, which would lead to chronic renal failure or adjustment to chemotherapy drugs, and risk of relapse may be seen there. And how can we manage that? Protein and electrolyte control diet and supplementation of electrolyte as needed. So that's all from my presentation. Thank you for being here, and then I'd welcome all the questions or feedback or comments on this presentation. Thank you so much.
Thank you so much, Juna. I didn't see any questions in the chat. If anyone would like to have unmute yourself, please do so. If you have any questions for Juna. Anyone would like to anyone have a questions for Juna? If not, later on, that's fine as well. You can have the questions. Okay, good.
Hi.
All right. Hi, Dr.
Hello.
Ola.
Yeah, just one small question. Thank you, Juna, for this very nice talk, and thank you, Teck Lim and Benson, for organizing this. You know, this nutrition problem is very important in childhood cancer because also not only they don't feel well, it increases the risk of infections and poor responses to treatment. So do you have any studies that show the correlation between poor nutrition and outcome to cancer treatment, Juna?
Thank you so much, Rala, for this wonderful question. Yeah, there are several studies which are, identifying the relationship between the adequate nutrition and survival rate. And they have seen that if a child is undernourished or overnourished throughout the treatment time, then they would have low survival as compared with the one who are having normal nutritional status throughout the time. I could share the study with you via email, or I could share that with CCI Asia. But yeah, I'd say that there is a relationship between. So thank you for the email. I'll share that study.
Thank you for that.
Thank you so
Well,
much.
we have a question from Dewi, right? Dewi, thank you for the presentation. And she asks from Indonesia, for patient experiencing anorexia nervosa, right? What steps should be taken to prevent malnutrition, and what types of food can be provided?
Anorexia nervosa, what type of food should be taken? So yeah, it's sometimes seen in a few children. It is sometimes parents are really forcing them hard to have some kind of food, and they are forced to have some kind of food, and because of that they are really not into that food. So
Right.
and
Carry on.
we need to the counseling is one of the good intervention for them, if we are managing anorexia nervosa, because it's and not only the nutritional aspect, we need to think of psychiatric aspect as well. A dietitian and then the psychiatric together can work to make this problem to have a solution for anorexia nervosa. From nutrition aspect, we can counsel them about calorie densing of the food, so that though they have small volume of food, but have more nutrient in that food. And so calorie rich foods like potatoes or avocado or nuts or seeds, incorporating that in diet may also be helpful in anorexia nervosa patient. So but dietitian alone I think is inadequate in managing anorexia nervosa. We need to work together with the psychiatric team as well. Yeah. Thank you for your question.
Right. So we have two more questions later on. Maybe Juna, you may want to answer that in the chat, or later on we're going to get back to you on that. It was a very good presentation regards to nutrition by Juna, right? So you really have shown us, nutrition not just about eating well, and I like the OS, right? The overall survival that we want to aim for, and how you go through the assessment to classifications, before you provide the right interventions. I think that's something is very important. So by the way, for everyone, with the consent of Juna as well as Dr. Maha later on, who's going to present, they have consented to circulate this deck, their presentation deck to you all. So you're going to have a lot of information there as well, especially when I was looking at the last piece about, the complications and the strategies. I think it was very, very helpful. Yeah. Okay, so with that, let's move on to the next one. Okay, joining us from Jordan is Dr. Maha Barbar, who's a consultant pediatrician at King Hussein Cancer Center. So trained at the Cleveland Clinic in the United States, Dr. Maha brings a unique combinations of clinical expertise as well as a regional insight. So she'll be sharing practical perspective and case insights on managing nutritional complication along with the lessons, that can inspire us. Linking back to what Juna, shared, So let's hear from Dr. Maha, who's going to share a little bit more. As a member organization of CCI Asia, King Hussein Cancer Center, a member organization sharing. She's going to share best practices as well as anything challenges that may come about. So with that, let's welcome Dr. Maha to present. Over to you, Dr. Maha.
Yeah, good time for everyone, morning, afternoon, evening. And I'm very thankful for the CCI to give us this opportunity to be part of this meeting. I'm going to present actually the practice of the nutrition support for children with cancer, exactly reflecting what Juna had said about the guideline and what's needed to support those children. I'm working at King Hussein Cancer Center. The center had been there since 2001. And actually started with one building, expanded to another 2 towers in the 2017. And we have a strategy to have a pediatric oncology hospital, hopefully by 2030. King Hussein Cancer Center is one of the member organizations with CCI Asia. This is just to give you an idea about our hospital. This is the main entrance of the hospital. These are the pediatric wards. We take care of children up to 18 years of age. We have 45 wards beds for pediatric, 9 pediatric ICU beds, and 17 beds for bone marrow transplant. All our rooms are single rooms, by the way, for children with cancer. Those are the playrooms and the educational room for children, because we do as well school teaching for children who have been in the hospital for a long period of time. So our clinical practice in general based on multidisciplinary approach, we have multi-modality clinics and teams, and the nutrition is part of those. We have like site-specific service team and like bone marrow transplant team, pediatric ICU teams, leukemia teams, and our nutritionists are part of those teams. They meet with them with their multidisciplinary meeting, and we follow a clinical practice guideline to unify the treatment approach for all the patients. This is an idea about our how busy our hospital is. This is up until 2022. We take care of up of 6,000 new cases. This is for both adult and pediatrics. There was about 18,000 admission, and I think this is like 2,500 outpatient visits. By the way, actually, the King Hussein Cancer Center take care of all pediatric patients with oncology, all the Jordanian, and as well as we are like a referral center for the other countries from the region, from United Arab Emirates, Iraq, Palestine, and neighboring countries, and Syria, of course. We have a good number of Syrian children treated in our hospital. So what's the King Hussein Cancer Center Nutrition Service? This is our team participating in the Childhood Cancer Day. And as we said, we follow policies. Our practice is guided by policy. For example, nutrition scope of service policy, that the nutrition unit supervises the patient's nutrition status through nutritional assessment, provide nutritional intervention, patient education, as well as supervision of the inpatient's meal. Patients who are admitted to the hospital, the dietitian will supervise the meal tray that had been prepared for the patients to make sure it's compatible with the order. We provide nutrition training for trainees from outside KSCC as well, continuous education and competency training for our KSCC dietitian. We cooperate with the community nutritional programs and activities, workshops and conferences, and we have KSCC research projects and quality projects participation as well. We have 3 pediatric nutritionists. The KSCC has 10 nutritionists. 3 of them are dedicated for pediatrics, that they cover the pediatric bone marrow transplant unit, pediatric wards, and ICU, as well as outpatient clinics. We have daily pediatric nutrition clinic that take care of the new patients who are referred for initial assessment, as well as patients who needs a follow-up, whether from inpatients or as outpatient follow-up. We have a pediatric bone marrow transplant nutrition clinic once weekly, and I do actually a pediatric medical nutrition clinic weekly. This will take care of any patients referred for medical purposes from the nutrition clinic. For example, patients who need appetite stimulant, or he needs a gastrostomy tube, then he has to be seen by the medical clinic to strengthen the nutritionist recommendation. We do have policies that we should follow, like the blended food policy, enteral nutrition policy. We have the nutrition scope of service, also the nutrition assessment and reassessment regarding the time frame, where to document, what to document in the electronic medical record. It has to be guided by policy. And we have the patient's education from the nutrition point of view, also guided by policy. As well as we have with sharing with the pharmacy, pediatric parenteral nutrition policy for TPN and adult parenteral nutrition policy. So regarding patient nutrition assessment and reassessment, this is to ensure the standardized nutritional assessment process, determine the time frame of initial nutrition assessment and reassessment, and monitoring the nutritional intervention. As per the recommendation from all the nutrition societies, every child with cancer should have the initial nutrition assessment before they start their treatment, whether the treatment is chemotherapy, radiotherapy, or surgery. And then they have to have a follow-up assessment based on their status. If they get admitted, we follow them upon admission regularly. If they are like solid tumors and they are managed as outpatient chemotherapy, they are given appointment with the outpatient clinic. But as you know, the most common malignancy in children is leukemia, and all of children with leukemia, they get admitted at least during the induction phase, and they get their nutrition care and education provided. Also, for regarding the patient in nutrition education, we have the handouts about the nutrition in cancer patients that's being given verbally, as well as a handout to the families and the children that illustrate the safety food measures to prevent foodborne infections. Like it has instruction how to shop for the foods, what to avoid, like to avoid open buffet food or raw meats. They have how to actually they have instruction also how to transfer the food to home, like if they have small refrigerators in the car, if they live away, they have instruction how to prepare the food to avoid like using the same equipment for meats or vegetables. We give them also the instruction how to store the food after it had been cooked. We give them the instruction for what we call a neutropenic diet or low bacterial diet, that things that they are not allowed to eat or to use in food preparation. So the KHCC nutrition service responsibilities, it's mainly the nutrition assessment as well as reassessment, provide recommendation about nutrition intervention, oversee the special meal prepared in the kitchen for the 3 meals daily to ensure compatibility with the diet order, and always they are part of the team. Our nutritionists are part of the team. They communicate with the physician, nurses, pharmacists, and they attend the MDCs, meetings, and rounds. They do the patient family education, and they participate in the quality projects. For example, we do quality projects regarding patient satisfaction about the food and the nutrition provided. We have quality projects about compliance with the nutrition referral process and the frequency of wrong diets served to the patient, for example. This is our kitchen, and actually we have, our dietitian has a very good interaction and communication with them, because as I will show you now, the type of diet that it's ordered for the patients, it is translated in the kitchen to be prepared the right way. So this is our kitchen. And by the way, KSCC had been accredited for nutrition and food service among other accreditation, like the Joint Commission International Accreditation. As you know, they do have some standards that directly related to the nutrition, like nutrition screening of the patients, screening criteria. We also accredited by the Healthcare Compliance Association, the CCA, and by the HACCP, which is the Hazard Analytic and the Critical Control Points, most internationally recognized system based on the production of safe food from preventive approach, and as well as ISO accreditation. So how do nutritionists get involved? Let's take the what Juna told us about the guideline and how to manage the side effect and take it into practice. At KHCC, the nutritionists get involved by referral. Following the policy says all newly diagnosed children with cancer should be assessed nutritionally prior to starting treatment. Referral upon diagnosis, and as well as whether they are in outpatient clinics or if they get admitted upon diagnosis, we see them upon diagnosis. ICU, all patients will be seen within 24 hours of admission with consultation. If no consultation was made, the dietitian will visit the patient and assess them within 48 hours maximum. For inpatient ward, screening for nutrition needs usually start by the nurses. If the patient is he's not a newly diagnosed patient, this is his second admission, for example, upon admission, the nurses, they do have screening criteria, which implies mainly, I will show you now, the screening criteria. If the patients meet any one of the screening criteria, then the patient will be referred to the nutritionist. If no referral done, the pediatric dietitian taking care of the ward will visit the patients maximum within 72 hours to make sure that there is no nutritional concern. Those are the nursing screening tools for nutritional concerns upon admission. If there is a weight loss more than 5% in the past 4 weeks, failure to thrive, if the patient is overweight or obese, if the patient showing signs of malnutrition like loss of subcutaneous fat, loss of muscle mass, if the oral intake is inadequate according to the family or parents report for more than 3 days, if the child has any symptoms that impact the caloric intake, like vomiting, diarrhea, constipation, nausea, mucositis, any patients on enteral feed, whether NG feed or gastrostomy feed, then the dietitian has to start following him up immediately after admission. And any checked item, as I said, mandate referral to nutrition service. So once the dietitian gets involved, referral, then she will start the assessment. The assessment consists of checking the weight, if there is any weight loss, and calculate the percentage, look at the growth charts, calculate the body mass index for the age percentile, and we do the adequacy of nutrient intake, 24-hour caloric intake and protein intake recall. Then they calculate the caloric requirement and the protein requirement based on equations. And we look for any gastrointestinal symptoms that affecting the oral intake and they can give the advice for the management of those symptoms. We take care of food allergy and food preference, religious food, for example, and we look at the laboratory results, the serum albumin, the pre-albumin, creatinine, electrolyte, and triglyceride. Part of the assessment, we look at the body composition analysis. We do have the bioelectrical impedance in the outpatient clinics. We use the mid-upper arm circumference and skin fold thickness as well. This is the electronic medical record pediatric nutrition assessment note that has to be documented in the patient's record, which has the diagnosis, the stage, treatment, the nutritional concern at this point of admission, the oral intake, as I told you, and the growth parameters, the body mass index, the weights, the ideal body weight, the adjusted body weight for the obese patients, and the caloric and the protein requirement. If there is any investigations that has relation to the low albumin, low pre-albumin, and then they assess, they write their assessment whether the patient is malnourished, well-nourished, or overweight, and any nutritional issue at this point of time upon the admission, and they have the plan of care. Now, the nutrition intervention or the plan of care depends. If it's symptoms related, for example, if the patient has dysphagia, we do have what we call mashed or puree diet for dysphagia diet. Mucositis, for example, we have a mucositis diet, soft, cold diet. Diarrhea, there's the anti-diarrheal diet, what we call Pratt diet. Anorexia, we might recommend, for example, appetite stimulant, like we use cyproheptadine, the Briactin, or migesterol. Then nutrition as therapy, the patients in need for a high-calorie diet, high protein, low sodium diet for hypertensive patients, diabetic diet or low glycemic diet for patients with hyperglycemia. This is the screen of the diet order in our electronic medical record, and the dietitian, with coordination with the physician, they will specify the best diet for these patients. For example, you can pick antidiarrheal diet, you can pick high fiber, high sodium, low sodium, soft cold diet, regular diet, renal diet. But all of these diets follow the neutropenic diet guideline, which is we don't serve from the start any green leaves food. We serve like individualized bottle of milk, individualized bottle of water or juices, all of it like individually packed. And then we see the patients based on the assessment if he needs nutrition support. Nutrition support, whether, for example, high-calorie diet, we calculate, we add extra food item to the tray, or we might need to use formula, like high-calorie formula, Pediasure, Ensure, this is what available in our country, Renamet, or elemental diet, for example, Neocate, Peptamen Junior, and we can add medium-chain triglyceride to add more calories. If the patient has any contraindication for gastrointestinal feeding or oral feeding, or oral intake is inadequate for any reason, which is defined as less than 60% of the requirement for 3 days in a row, we use the enteral feed. Nasogastric, or if the patient has gastrostomy tube, usually those for patients, for example, with nasopharyngeal carcinoma, we use the gastrostomy tube. If there is contraindication to use the gastrointestinal tract, or still the enteral feed, we are in the beginning of the enteral feed and the calories are not optimal, we have the facility to give parenteral nutrition, whether central, through a central line or peripheral access. And the parenteral nutrition order is kind of coordinated by a team, consists of clinical pharmacists that's responsible for that ward, the physician responsible for the patients, and the pediatric dietitian in charge of the patients. Then we have to assess the impact of the nutrition support on regularly based on the nutrition support. For example, for patients who are on enteral feed, we keep following them up daily until we reach the maximum goal of calories needed, and then we see them twice per week. For patients on parenteral nutrition, they have to have a daily follow-up by the dietitian as well as the team to monitor their electrolytes, caloric to advancements of their TBN or any side effect from the TBN. This is our pediatric parenteral nutrition order that's usually used in the center, written by the physician in under the recommendation of the dietitian and the pharmacist. Regarding patients and family nutrition education, it depends on the nutritional status of the child, the requirement of the calories and the protein. It might tackle the treatment side effect that might affect the nutrition. As Juna said, the side effect like mucositis, we have a handout about how to handle the mucositis from the nutrition point of view. For example, dysphagia, the food advice for diarrhea, in case of taste of change of taste. We talk to them also about food-drug interactions, food safety measures, the low bacterial diet, the safe preparation, and we have actually recipes for high-calorie, high-protein diet as well that can be given to the family as instruction, as a support, and those are all in handouts actually. All our handouts are in Arabic, but we have the printed in Arabic, but we have the translated handout in English for non-Arabic speaking patients. And this is, for example, for people who don't read Arabic, this is about the safe food for patients with cancer that educate the patients about the food that is allowed and the food that should be avoided. This sheet is about the instruction of the diet during admission. We don't allow them to bring food from outside unless they get the okay by the nurse or the dietitian responsible for the patient. Those are other handouts regarding the mucositis diet, bone marrow transplant diet, and in children with diabetes, for example, diet after surgery. So we have it all printed out to patients. So with that, we still have challenges. I'm sure like we try our best to follow the guideline to do for our patients, but the challenges are, for example, availability of nutrition formulas for outpatients, because we provide the nutrition formulas for inpatients. But once they are outpatients, once they get discharged, the formula is not prescribed for them. So they have to buy it on their own and not covered by the insurance. And I'm sure this is a problem for the patients because, as you know, most of the therapeutic formulas are costly. And sometimes because of the socioeconomic status being a middle-income country, for example, some of the patients and families, they have a limited income that they cannot support the nutrition of their child. Also, the interfeeding challenges. Sometimes we find the child is not taking enough regardless what you do, regardless all the instruction you give, regardless the appetite stimulant you provide. So the enteral feeding is mandatory. So we talk to them. Parents sometimes get less acceptance to the enteral feeding. Also, sometimes the oncologists themselves, they feel like nutrition it's important, but let me take care of the chemotherapy, for example. Let me take care of the surgery. Those are more important. So sometimes the oncologists actually support for the implementation of enteral feeding. Sometimes we have the problem with that. And as you said, formula availability. Like if you put nasogastric tube for the patient, sometimes we have to manage with like blenderized food, cocktails, something like that, which most of the time still costly and might not be available. Also, we have problem with the compliance of the children and families with the dietary and food safety instructions, what to avoid and what to give. We try to overcome this with education workshops, but still, those are challenges that we face. And by this, I end my talk.
Thank you. Thank you, Dr. Maha. Right, a big round of applause to Dr. Maha for sharing. Wonderful. In terms of what I call that, the way that you've been sharing is very grounded. Your presence is very grounded, and we really appreciate the practical lens that you brought to today's sessions. Even though we know that's important, the multi or disciplinary, right? It can be quite wide, quite overwhelming. So for some of us, but I believe there are certain areas, small steps that we can take, small action that we can kind of take at the local level to start looking at it. And I like how you also kind of shown us, while challenges exist, I believe what you presented and what Juna presented earlier on as well, if we have a system, built on clear protocols, family engagements, and ongoing follow-up. And I believe all these are very relevant to every member organizations to really consider, as we move forward. Thank you for that. And I really appreciate both you and Juna presentations. Now we're going to move to the breakout room, okay? So as we prepare the breakout room, I encourage you to reflect the valuable insights shared by both our speakers today. So think about how these ideas connect with your organizations, right? Practices. It could be your needs. Some of you mentioned that you are yet to start the nutritional program. So it could be start with your needs, or it could be your practices, or it could be your challenges. So you can come together in the small group to really share. In the small group itself, so remember what I said earlier on, okay? I gave you a heads up that we need a moderator. So I hope that someone would raise their hand and say, okay, let me help in this particular session as a moderator. And as a moderator, your role is important, but it's very simple. You are basically helping to guide the conversations and make sure that every voice is heard within the group itself. Yeah. So there'll be 7 groups that we're going to put in, maybe less because some have not turned up for this session. So later on, when you're assigned to a room, just click join and you'll be directed to the respective breakout room. So the facilitation is basically we want to reflect on our key learnings from our subject matter expert as well as a speaker. So your role as a moderator is to guide, as I mentioned, and support. One thing is that Chris is going to put into the chat again the template. And in the template, you may, as a moderator, you may capture all those notes, or you may assign someone to help you to capture all those notes. So we need to have a note taker as well, So here is basically some guideline. Sorry, and those guidelines, you have all this in the document that's going to be in the chat that Chris is going to post there, yeah. And it's basically, as a moderator, you may just need to keep time within 3 minutes, get to know each other, quick introductions. After that, go to reflections with some of the question prompts that you have there. And then what could be the application? And some of you may want to share your own local practice within the group itself. So there could be some question as well. Take those questions. So a note to all the moderator. Please, capture those notes in the discussions in the template, and from there you will basically need to send this over to Chris. Don't need to be perfect, no need to be long sentence and so on. Just capture some of the key messages there. Okay. So it's gonna be 20 minutes for your breakout. Within the 20 minutes, follow this session. Actually, this session is there's 25 minutes. So try to cut it down to 20 minutes. And then we'll give you a prompt. Once you're halfway there, 10 minutes, we give a prompt in the announcement. And after the announcement, 10 minutes, then we go to 5 minutes, then we have 3 minutes. And then the last minute, you'll be brought back to the room. Okay, you'll be brought back to the room. So once that's done. Okay, so with that, is there any questions that you have before we put you into the breakout room? So do download the template from the chat room. And I believe, Chris, are we still on assigned 7 rooms, or going to be less, Chris?
Still 7 groups, but lesser people.
Okay. Lesser people, good. Because lesser people, you have more time to have more discussions. That's why we cut down the time as well to 20 minutes. So just try to follow the guides there as a moderator, right? You'll be able to help guide the whole group in the discussion itself. So if there are no discussions, Chris, you may proceed to open the room for everyone, and then we give an announcement as we come back in 20 minutes, yeah? And Benson, we'll continue to refine it as we go through each experience. Yeah.
In my group, it was only a few people, but a very good discussion. Again, we find some useful information for the organizations and for us too.
Yeah.
Yeah, absolutely. We had just 3 people with me, but very, very useful discussions. Lot of suggestions of what we could work, with at a CCI level also. So, I mean, I'll share that with the group later. And, I think we need to have a follow-up on this exactly, even with the participants. So we know how they benefited or how we can take this forward.
Right. Yeah, thanks, Usha, for that. I think the small group really helps as well to have a better, more time for each other to discuss as well.
Yeah.
Okay, welcome back, everyone. Welcome back. I trust that there's, There are meaningful discussions in the breakout groups. That's one of the basically the purpose behind Bridges of Hope is to give opportunity to connect and also to share in a smaller group, whereby we can able to listen, to reflect, and to learn from each other's experience. Yeah. So every single idea that you all shared, whether it's no matter how small is it, right? We can always take it to the next level in the local within your respective organization. So to our moderators, a reminder, please help to send the notes that you captured to Chris based on the email that you have on that particular template. And then we'll compile that and just like what Usha just mentioned, there could be a follow-up with those people in the respective group. So now we're going to move into the closing of the session. Yeah. So for that, I think before we go that, Chris, why not we have a group photo, Chris? Before we forget, So let me stop sharing.
Yeah, you've lost participants. We were twice the slide.
Yeah.
But still good size here. So everyone turn on your camera.
Yeah, if everyone can just turn on the camera.
Everybody disappears.
Yeah. Give me a big smile. The biggest one you can give.
Yeah. Come on. So everyone.
Let's try.
See you, Chris.
Not going yet. We're taking group photo. Don't say goodbye yet.
Not yet. Some announcement.
Okay. Yeah. 1, 2, and 3. Just hold on to your smile.
Yeah.
Okay, I need to do go to the next page. Okay, and the one. Okay, we're done.
Thank you.
Great.
Okay.
Good.
Fantastic. So we'll send you by email the discussions in the small groups, what we had insights, right?
Yes, please.
Yes.
Yeah,
we'll
send it to me, Chris.
Yeah.
We'll
send to Chris directly.
Fantastic. Yeah. Great.
Okay, so and we still have some administrative thing to go through. If you all can help to just give some of a feedback in the feedback, scan this QR code. If you need a link, Chris, you put into the chat a direct link. So
but it says bereavement. It says bereavement virtual training.
So there's a mistake. Thanks for pointing out that. Good catch. So don't worry. So I think we didn't update the slide there. Yeah. So my mistake. So just the QR code is correct. We're going to go through that assessment. So when you come to question 5, think about your local actions. And once you have some local actions, do share with us as well, how you have implemented some of the concept, the ideas, from this session on nutrition. And on question 6, if you see there's a need, for your organization to launch a nutritional program, if you need support, do write in. Just put your indication there. If you need that, you put a yes. And Chris will reach out to you to get more details to see what actually the support that you need. Like Dr. Maha has shared, they have a nutritional training, things like that. There's always a support within our member organization who's able to provide some mentoring. So currently we are also with one particular mentoring program, we are currently in a matching. So if any organization already implemented, you can always raise your hand and say we have some good nutritional program that we can support a member organization. We will link you through some of the organizations that need the support. Yeah. So one thing we will basically circulate the deck from the speakers for you. Yeah. So Juna, you have questions or you're done? Dr. Maha, you have questions? You want to share something?
No, actually, I have a comment that, as I said, we are doing training for nutrition And we have agreement also with the IAEA, International Atomic Agency. We are training program for nutritionists. So we'll be happy for any center who needs any training to have some people in-house, and we can provide training.
Wow, thank you so much for offering that support, yeah, to the Maha.
Yeah.
Good. Thank you so much. Yeah. Oops. All right. So if there's no further questions or comments, really appreciate this time together. Thanks to Juna, thanks to Dr. Maha for your sharing. Really appreciate all the insights and expertise that you share with us. Yeah. To what I call that, our moderators, thank for stepping in. And we need more of you in our future, what I call that, Bridges of Hope program. And you know that, if you need support, if you have questions and so on, always reach out to myself, Benson, or Chris. I really appreciate Chris also working behind the scene, messaging you all, communicating all the announcement, things like that, and especially for this particular station as well. She's also our program producer behind the scene. Thank you so much, Chris. Okay, so if there's no other things, stay in touch, stay safe, and happy holidays. This is December, and to those who are celebrating Christmas, Merry Christmas to you. All right. So thank you all so much. Bye.
Thank you very
Thanks.
much.
Bye,
Thank you,
everyone.
everyone.
Thank you very much.
Bye.
Bye.
Thank
Bye.
you.
Thank
Thank
you. Big
you.
hug
Bye-bye
to
for now.
all. Merry
Bye bye.
Christmas.
Bye.
Christmas. Bye.